Welcome everyone to today's BlomCon seminar. I'm Dia Waguespack in Houston, and today our talk is titled Old and New Challenges in the Diagnosis of Podocytopathies. Today, we are very thankful to have Dr. Helmut Rennke.
Well, thank you very much for inviting me to give this talk. Like so many aspects in medicine these days, we have old challenges and we have new challenges, of course. And so I'm going to go through this. I'm not going to tell you about big studies and statistics. I will approach this like I frequently approach my talks with cases that reflect all these challenges. So I have put here very in big letters my email in case any of you have any questions or concerns later. There are some technical challenges, of course, in renal pathology, and some psychological and psychiatric challenges and what have you. Well, you may not have heard my type of view of the podocytopathies, but here is, in a way in which we can dissect the topic of the podocytopathies. Obviously, when the damage is diffuse, it affects every nephron is salt retaining, and you will have the full nephrotic syndrome with edema and hypoalbuminemia. When the damage of the podocytes is only focal, affects only certain loops and certain, you have a focal damage, in which case you have proteinuria that is usually in the non-nephrotic range. Of course, these diseases progress into more diffuse, and eventually what is at one point non-nephrotic can potentially develop into the nephrotic syndrome when the damage accrues more and more nephrons. These diseases can also be viewed, both the diffuse as well as the focal podocytopathies can be viewed also from the point of view of the causes or the mechanisms. And we have therefore four windows. A window of the acquired conditions that can be diffuse or focal, and the genetic conditions. Now, one of the big challenges, and I will tell you right from the beginning, is that we view these windows as separate and isolated. Well, there is a lot of interrelationship between one and the other. There are many conditions in which the genetic aspect plays a critical role, and we have only an acquired trigger, and therefore there is a lot of movement between all these windows, and therein lies a part of the challenge. So let me first start with the diffuse acquired podocytopathies. We will not discuss much cases of the focal damage or the diffuse genetic damage, and I will at the end also hopefully get to one of the cases of focal damage with genetics. So here, obviously, here is the group of what we consider acquired, but remember, all of these cases may have predisposing factors. There may be polymorphisms, there may be VURs in many of them, and therefore keep in mind that this is just an artificial way of looking at it to simplify things and to concentrate on particular aspects. So here we have minimal change disease, toxic tubulopathies, idiopathic primary focal sclerosis, which I think is similar to minimal change disease. It's just a stage in which you have accrued more irreversible damage in the glomeruli. Obviously, the membranous nephropathy can be viewed as a diffuse podocytopathy. I'm not going to touch that at all. Also, a subgroup of this, the podocytic infolding glomerulopathy, is probably also an antibody-mediated form of injury. And obviously, the collapsing GN. Notice here that the collapsing GN appears in every window, because it has acquired triggers, but it obviously has a very important genetic component. And again, this is probably very popular right now, and we know a lot about APOL1 associated GN. But you need to keep in mind that many of the other conditions that we consider strictly acquired may have vulnerabilities factors built in not only for the initiation of the disease, but probably also for the progression of the disease. So to begin with, let me tell you that this first case is not a mystery. This is a case of minimal change disease, but I will discuss a few of the challenges. This is a 41-year-old man that present with acute swelling of the uvula. Eventually, the swelling begins total body swelling, and he has obviously heavy proteinuria and a protein to creatinine ratio of 15. He denies any of the classic triggers that one looks for in these cases. There is no significant past medical history. So a classic presentation, the patient has a 17-pound weight gain over the last few weeks. He has 2+ edema and 3+ protein, 1+ blood, which is not unusual to find in patients with sudden onset of nephrotic syndrome for various reasons. The creatinine is already 1.5 at this point, and very often the challenge is to figure out, is this an acute kidney injury, not infrequent in the cases of sudden onset of nephrotic syndrome for the various reasons that you all are familiar, and therefore we frequently kind of ignore this aspect of the minimal change disease, but there is often tubular injury. Well, the biopsy was performed, and obviously what you have here is a normal-looking glomerulus and a sea of tubules that look a little more distended than they should look, with maybe a missing brush border or flattening of the cells, and this reflects the acute kidney injury that we frequently see in this disease. All very well-known aspect. Completely normal looking glomerulus. Silver stain doesn't show anything, but the patient has diffuse effacement of foot processes, as you can see here, with microvillous changes of the cell surface of the podocyte, no electron-dense deposits. The basal membranes in this case look pretty normal in thickness, so there is no issue of superimposed or an underlying collagen 4 disease. This is just to compare what a normal interdigitating foot processes should look like at a similar magnification here. So often missing, and the challenge often is to find these defects, and this is not an artifact, in my opinion, where the basal membrane is naked, has lost the epithelial cover. It is these areas that are hyperfiltrable to water and electrolytes, and therefore these are the areas that represent the large pore system of the physiologist that I think many people have forgotten or have stopped reading about this. But these are the large pore systems that allow proteins to pass through, and therefore you have proteinuria. So the first challenge is to view some other biological markers or molecular or in this case structural patterns. What we have observed for the last about 20 years